In this session, we'll talk about the normal changes in pregnancy. As usual, we start with a case. A 32-year-old female primary gravida who presents to the emergency department in her third trimester. She has noticed some swelling of her feet and sometimes feels dizzy on standing. On examination, her blood pressure is 107/62 with a pulse of 98 beats per minute and an SpO2 of 99% on room air. Her respiratory rate is 28 breaths per minute. So what I want you to do is pause the video, look at this entire presentation, and make some notes on some of the normal changes in pregnancy that you think may have occurred to account for this patient's symptoms and for her vital signs. So by the end of this lecture, you'll be able to outline the changes in pregnancy, and we're going to divide these into hormonal, physiological, and anatomical changes, and talk a little bit about how each of the categories interacts with the other. So this graphic shows the changes in some of the key hormones in pregnancy during the course of pregnancy. This orange line represents human chorionic gonadotrophin, HCG, which is the hormone that we test for in early pregnancy to diagnose pregnancy. And as you can see, it peaks at about the 10th week and then starts to fall off. This hormone is produced by the syncytial trophoblast, and it's really concerned with the development of the trophoblast and the growth and development of the placenta. The other three hormones that are of concern to us are progesterone, estrogen, and human placental lactogen. The progesterone is involved with the development of the endometrium to facilitate implantation, the development of the uterus, and also is a very powerful smooth muscle relaxant to inhibit uterine contractions as the pregnancy proceeds and progresses. It also has quite widespread effects on other parts of the body, including soft tissue, including the vagina and genital tract, and it may be associated with the development, for example, of edema in the pregnant female. Estrogen is also important in the development of the endometrium and the placenta, and has some effects on the development of secondary sexual characteristics during pregnancy as well. Human placental lactogen has prolactin-like activity, but rarely a lot of its effects has to do with glucose metabolism. It produces a state of insulin resistance in the mother and also decreases glucose utilization and increases glucose levels in the blood. And this really facilitates the use and the provision of glucose from the mother to the fetus. So in terms of glucose utilization in pregnancy, the fetus is prioritized over the mother. And to counteract this in terms of energy production in the mother, HPL also enhances lipolysis and therefore provides an alternative energy source for the mother. There are other hormonal changes seen in pregnancy as well. the pituitary increases in size, and this is mostly due to hypertrophy of the posterior pituitary and an increased production of prolactin, which is very important in the development of breast tissue in anticipation of lactation. The adrenal gland increases the production of both cortisol and aldosterone, leading to salt and water retention, as well as hyperglycemia and some degree of insulin resistance. Again, you can see that this promotes the use of glucose in the fetus because it increases hyperglycemia, reduces insulin sensitivity, and therefore shunts glucose from the mother to the baby. Thyroid hormone is increased already because of an increase in thyroid binding globulin and an increase in the total T3 and T4. However, free T3 and T4 and thyroxine activity is not as affected. And parathyroid hormone is increased, leading to bone resorption and calcium mobilization, again to ensure that there is sufficient calcium for the baby to for normal development of the skeletal system in the fetus. So what physiological changes might occur? Well, we're going to look at each of these systems, and again you might want to pause the video and just make some notes of what you know might happen in pregnancy in the cardiovascular and respiratory, hematological, renal and gastrointestinal systems. And here are some of the changes. So as far as the cardiovascular system is involved, there's about a 50% increase in the total blood volume in a pregnant woman because of the placenta, and that leads to an increase in cardiac output, both because of an increase in heart rate and an increase in stroke volume. At the same time, because of the effects of progesterone, the systemic vascular resistance drops, and there may be some effect on venous return, particularly in late pregnancy due to IVC compression. There is an increase in both minute volume and tidal volume in the pregnant woman because there is an increase in oxygen consumption with the baby on board. However, there are, in late pregnancy in particular, there are changes to the lung volumes with a decrease in expiratory reserve volume, functional residual capacity, and residual volume. Therefore, at this stage of pregnancy, you do find that to keep up with the increased respiratory rate, the increased minute volume, there's more of an increase in respiratory rate and also more splitting of the diaphragm. Pregnant women have a dilutional anemia due to an increase in both red blood cell volume and serum volume, but the increase in serum volume is greater than the increase in red blood cell volume. They tend to have a hypercoagulable state and a degree of immunosuppression, really, so that they don't reject the baby, and this is due to an increase in their cortisol levels and other changes in the immune system. However, it's normal to have an increase in white blood cell count in the pregnant woman, mostly due to an increase in neutrophils. Because of the increased blood flow, there's an increase in renal blood flow and glomerular filtration. The effects of progesterone on the smooth muscle of the ureter and compression from the enlarged uterus can cause hydronephrosis and hydroureter, as well as urinary stasis, which may predispose to urinary infection. Because of the increased glomerular filtration rate, patients may also experience glycosuria, and there's also an increased risk of proteinuria. The effects of progesterone on the gut leads to decreased motility, constipation, decrease in sphincter tone, and increase in gastric stasis, and as you can imagine, that all leads to an increase in reflux. Patients may also have physiological cholestasis, and this may be severe enough to produce jaundice in a small percentage of patients. The anatomical changes include changes to the uterus, increased size and vascularity, leading to compression of surrounding organs. The cardiovascular system, the ECG shows left axis deviation, and as we said before, the gravid uterus may cause IVC compression. Changes to the upper airway, including mucosal edema, obesity, engorged breasts, and a worsening Mallampati score, leading to difficult intubations, particularly in late pregnancy. And changes to the musculoskeletal system. Patients get an increasing lumbar lordosis, cervical kyphosis, and ligamental laxity. They end up with a waddling, wide-based gait, postural instability, decreased balance perception, and therefore are at an increased risk of falls. So if you have any questions, you can bring them up in class. We've looked at the hormonal, physiological, and anatomical changes in normal pregnancy, and I hope that this will help you understand some of the challenges in pregnancy, particularly with regard to the anatomical changes and the physiological changes. You should really focus a little bit as well on the changes to glucose metabolism and the increased risk of gestational diabetes. Thank you.